next speaker from Shengjing Hospital, Professor Ying Huang. She will bring us a new aspect of clinical use of SRUS. And today her topic is revolutionizing clinical application of SURS microscopy for adenomyosis. Thank you. Welcome, Professor Huang.
Thank you for the monitor. Good morning, ladies and gentlemen. I'm Ying Huang, coming from Shengjing Hospital of China Medical University. It's my great honor to be here to share and communicate with the more technique about the URM. So this time I will share the clinical application of ultra-resolution microscopy for adenomyosis diagnosis and treatment. As we know, the endometriosis is a chronic condition with a large impact on the patient's quality of life and is a leading cause of chronic pelvic pain, CPP, and is often associated with infertility. From the statistics, we can find about 10% of reproductive age suffer from endometriosis, and 20 to 50% of infertile patients are complicated with endometriosis, and 71 to 87 of CPP patients have endometriosis. The syndrome, including the infertility, anemia, miscarriage, preeclampsia, preterm labor, and intrauterine growth restriction. So from guideline and expert consensus from Chinese, the endometriosis treatment is from radical surgery to pain relief, fertility improvement, comprehensive treatment, and long-term management. But to be a special endometriosis, malmetrosis is a special disease, and the diagnosis of this kind of disease is not enough. From the different level need different management. For example, the level 1, the target population should be exposure to risk fractions in susceptible population. And for the level 2, the target population is symptoms but do not require surgery. For the sonography, we are pay more attention about level 2 because we should give the patient more accurate diagnosis and even interventional therapy. And level 3, for the target population, need to surgical treatment and to long-term post-operative management. Let's look at diagnosis of endometriosis. And during the clinical process, we need a clinical examination and imaging. For example, ultrasound and MRI. Step by step, we give the patient accurate diagnosis. But for the diagnosis, ultrasound is the first line diagnosis method, but there is more space we should improve. For example, we cannot give the early diagnosis of endometriosis and cannot to stage the picture about the phenomena. From the 2022, the MUSA has classified myometrium into 8 subgroups from A to H. Except the gray scale method, there is F subgroup. We can do more attention about the vessels display. And based on this, we can do more staging, but we cannot give as accurate method as MRI. First, let's look at the vessels displaying method. We use CEUS. We can use Bunner's injection into the vessels to see if the lesion has different displaying. They can be early perfusion of the lesion with high enhancement. Also can be plunged into the lesion with heterogeneous low enhancement. Also can be delayed perfusion from the peripheral towards the center, and at last it can be SO enhancement. So it can display different types. But because the sonography technique limited, the CEUS only to display the bubble blobs or bubble clots. So let's look at the microvascular network. During the body, there is more than 10 billion vessels. And the clinical significance, including the exchange of oxygen and the nutrients, also related to the occurrence and the development of disease. But during the clinical process, the color CDFI or the power Doppler can display the vessel's diameter from 200 to 500 micros, and the microvascular flow imaging can display 100 to 200 micros. But now, ultra-resolution microscopy, we call it URM, can display less than 50 micros about the diameter. So we can do more about our research work. And we use this method to do the myometrium lesion displaying. We use Ultimus 9 and use the convex array transducer is IS1 to AC, and use the frame rate range from 70 to 100. During the process, we choose the patient to take their host about 10 seconds, and during the CEUS just display and to record the date. After that, use the microbubble separation and tracing the bubbles to generate the image to see what's the lesion displaying. And from the picture, we can see the upper line, the three pictures are adenomyosis, and the down line is the uterine fibroids. It's different. We can see the adenomyosis, the border is indistinct, and the vessel is very tiny. But for the uterine fibroids, there is a surrounding vessels. The diameter is larger than the adenomyosis. Beside this, and we can see the uterine fibers can show more bigger vessels than adenomyosis and the instinct border. Besides this, we can use another direction imaging to see where is bubble flowing. We can use the multiple imaging to see the bubbles from the endometrium to the border of the uterine. We can see where is the bubbles flow. And after that, we can do quantitative analysis, including density gram, flow engine diagram, and velocity direction, and so on. But most important is the complexity value. We can split the map into very smaller grids and to calculate the slope of the vessel's change to indicate the vessel is steeper or flatter. Steeper means the vessel's complicated or twisted, and the flatter slope means the structure is simple. And from the picture to compare, we can find that complexity, density, and blood flow velocity of the macrovessels of significant importance in evaluating the severity of adenomyosis and differentiating it from a typical fibroid. Also, we compare the microvascular distribution of and MRI signals. We can find the higher of T2 of adenomyosis, the less than the fiber tissue components, and the lower the echo on the ultrasound image, and the richer of the blood vessel density. Besides this, there is a therapy for adenomyosis, different choice, including surgical treatment, drug treatment, and IUS. But we know the boundary of adenomyosis is undistinct. So the surgery has proven to be effective only in 50% of the patient. And drug treatment only suitable for the women under 40 years old. And IUS only suitable for small uterus. So interventional ultrasound therapy will be a promising method for treating this adenomyosis. And from the literature has proven that the ablation therapy is effective, improve fertility, and protect organ function. But during the process, the doctors has made some question. For example, the hyper range and the ablation range are different. This picture we published in URM, and we found use different muscle, liver, different method, microwave or radio frequency, and different power, different time. We can find the ablation range and hyper range are inconsistent, sometimes overestimated and sometimes underestimated. That's because the hyper range, including the vaporization from the water to gas and the disintegration of the tissue, so the border is not clear, it's coarse. We want to know the accurate border of the lesion is very important. So we want to use this method to see if we can get a clear display of the liberation, because during the ablation, we cannot know the exact electric field, exact thermal field, and ablation zone. But during the process, we know the bubble, the gas will influence the displaying. So we also to estimate the range from the bubbles, but use the URM because the bubbles are not flowing. So it should not be by tracing to display the vessel structure, architecture. We use this method to find that during the intraoperative, we can find there is no flushing of the bubbles. So we can know the exact border of the lesion. Also, after the operation, during the follow-up, we can also use this kind of method to see the boundary of the lesion, to see the density of the surrounding tissue and the velocity of the surrounding tissue. So we believe this kind of technique will give us more information during the diagnosis and the treatment. In the end, there is a spectrum. We want to know if their technique can be improved to see more deeper organs. We know there is a big step from the superficial organ to abdominal organ is a big step. The depths of the organ can be shown clearly, but it's very difficult for the technique because the deeper the organ, there is more motion correction. And this is the first aspect. The second is the CEUS noise. Different organs has different standard. For example, for the superficial organ, maybe we can to get the data from the peak. But for the adenomyosis, for the uterine, we should to acquire the data from the bubbles from the beginning of the flushing to get the data. And we want to know if there is a standard during different organs. And the third aspect is about spatial structure, because we use the single section cannot to be on top of the whole lesion. We want to know if there is a three-dimensional architecture of the vessels. There is a whole architecture of the vessels to show where is the most lesion we should diagnose. So there is a spectrum. I think maybe during the process, the clinical, and we can get more inspired to get more research work to improve this kind of technique. That's my report. Thank you.
Thank you so much for Dr. Professor Huang Ying's presentation for us.